So next topic is iatrogenic biliary injury, and this is V18. So what do you tell your patients during the consent process for laparoscopic cholecystectomy? So overall, this is a safe procedure with a low incidence of complications. There is a 1 into 40 chances of conversion to open, that is makes 2.5%. There's 1 in 400 chances of bile duct injury, that makes 0.4%. There's a small risk of bile leak, post-operative bleeding, infection, port site hernia, change in bowel habits, and persistent pain. There is 1 in 25. There's 1 in 25 chances of common bile duct stones at the cholangiogram, which potentially require further treatment. As with their operation, there is a small risk of chest infection, deep vein thrombosis, and pulmonary embolism. So while on call at District General Hospital, your registrar calls you from theatre regarding a difficult emergency laparoscopic cholecystectomy. The patient is 23-year-old female who was admitted yesterday with acute cholecystitis. During a difficult dissection, the ST7 says he can see bile but cannot see where it is coming from. How would you manage this patient? So first of all, I will tell my registrar over the phone, stop everything, no more dissection, I'm on my way. So firstly, I would tell the ST7 to stop the dissection and then go to the theatre myself, that where I would read the notes, look at the pre-operative imaging reports and assess the situation. I would not attempt to repair this laparoscopically. This is nearly always unsuccessful. I would consider the possibility of unappreciated or missed injuries like resection of the common bile duct, arterial injury, local diathermy injuries. If there was an obvious hole in the CBD, I would insert a T-tube. I would take the photograph of the dissection and place a large Robinson drain in the subhepatic space. I would wash out the abdomen and start the patient on broad spectrum antibiotic like tazocine. I would refer the patient to the local HB specialist unit for definitive treatment. Finally, I would have a debriefing with my SPR to go over the challenging points of the case and use it as a learning opportunity. How could you establish the source of the leak? So conduct a post-operative MRCP followed by ERCP if necessary to confirm the diagnosis and allow stent placement to treat a small leak. If the CBD has been completely transected, I would proceed to CT to delineate the anatomy. Biliary injuries are also associated with the vascular injuries, and hence the detailed imaging is essential prior to making a definitive management plan. How are biliary injuries classified? So biliary injuries are classified by two systems. For laparoscopic cholecystectomy, it is a Strasberg classification, and for old open cholecystectomy, it's a Bismuth classification. So Strasberg classification is 1 from cystic duct or from the gallbladder bed, 2 from the right hepatic sectorial duct, 3 again right hepatic duct, 4 from CBD, lateral wall of CBD, and 5 complete transaction of CBD. This is Strasberg. And the Bismuth, if stump is more than 2 centimeter, 1, stump less than 2 centimeter, 2, at the confluence but still confluence is attached, 3, confluence got 4, and 5 is I think sectoral branch. So what are the common variations in the bile duct anatomy? So right hemilever, right anterior or right posterior sectoral duct insertion directly into the left hepatic duct, right posterior sectoral duct insertion below the right and left duct confluence. This is dangerous if it inserted into the cystic duct. What is the risk of biliary injury during cholecystectomy? So 0.3207% open left cholecystectomy, 0.13% open cholecystectomy. It occurs in elective straightforward cases as well as after the pancreatitis, cholangitis, and emergency cases. The main cause is misinterpretation of biliary anatomy. CBD confused with the cystic duct. Associated injury with the right hepatic artery can also occur if it is mistaken for the cystic artery. Partial injury to CBD injury can occur from diathermy burn or after the rigorous traction on the cystic duct and avulsing it from the CBD. How can you avoid a biliary injury? Risk factors are inexperience, aberrant anatomy, and inflammation. These are summarized as dangerous anatomy, dangerous pathology, and dangerous surgery. A recent study showed that with visual perception, illusion is the most common cause. 75% are missed intraoperatively. Dissect Hartmann's pouch at the junction of the gallbladder and the cystic duct and identify all structures in the Kellett's triangle prior to ligation. Strasberg's critical view of safety. So don't say critical, say Strasberg's critical view of safety. Critical view of safety can be achieved by clearing all the fibrohepatic tissue between the hepatocystic angle and dissecting lower 1/3 of the gallbladder from the liver bed. When this is done, two and only two structures, cystic and cystic artery, should be crossing the Kellett's triangle and entering the gallbladder. Sages has advocated safe cholecystectomy program with this entails 6 steps. Number 1, obtain critical view of safety. Number 2, intraoperative time out prior to clipping, cutting or transecting any structure, understanding anatomical aberrations, liberal use of cholangiography or other method to image the biliary tree. 5, random recognize the approaching zone of significant risk and consider open conversion, cholecystostomy, tube placement, or doing subdural cholecystectomy, and call for help. 25% of the patient have drainage of the right scleral duct directly into the common hepatic duct, and this can have a prolonged extrahepatic course, being mistaken for the cystic duct. There should be no blind clipping of the arterial bleeding. Some surgeons advocate intraoperative cholangiography, laparoscopic ultrasound in every case to avoid injury. Routine intraoperative cholangiogram can reduce the risk of injury by twofold for inexperienced surgeons. It can be interpreted incorrectly and injuries can still be missed. Thank you.